I guess three main risk areas: the southern Manitoba, northwestern Ontario, and then southern Ontario and Quebec, and the Maritimes. That it is the risk is predominantly in woodland areas and peri-woodland areas where the ticks survive. And when we're in the woods, they're not kind of falling off the trees. They are crawling up from the herbage towards us. And there are three main factors that control where the tick populations occur, and that is climate. It's got to be warm enough for them to complete their life cycle. There's got to be suitable habitat for them to survive the cold over winter and heat and desiccation in the summer. And there's got to be enough of the hosts for the ticks, which are because the ticks are parasites all the way through their life cycle. How we measure risk in the environment is really, it's how many ticks there are multiplied by what proportion are infected with the bug in question, in this case, Borrelia burgdorferi. So where pacificus occurs, Ixodes pacificus, the risk is low to moderate because the ticks are, they don't quest very high in the herbage and they've got low prevalence. Dermacentor variabilis is occasionally you'll find ticks infected, but the bug, once it gets from the gut or tries to leave the gut of the tick to get to the salivary glands, it's zapped by the tick's immune response. So the actual risk there's lots of ticks. People get bitten by these a lot. There are other bugs transmitted by this, but Borrelia not. And then Ixodes scapularis, when you've got lots of ticks out there, they're happy to bite us, and there's a high prevalence. We have, and we've known for quite some time, there's a wide geographic area of ticks appearing in our passive surveillance system, most likely dispersed by migratory birds, which then basically half a continent worth of birds leaves and enters Canada every year, and when they come back when the nymphs are active mostly. And so we end up with adventitious ticks. Now, these, I think, are a problem for people diagnosing Lyme disease and also interpreting the risk. But the risk is much greater where we've got reproducing populations, because these are notional calculations, but it gives you an idea that where the tick populations are occurring, the adults which can bite us and be infected, there's many more of them, and also the nymphs of the tick, and there are many more of them in reproducing populations that you ever get brought in by migratory birds. So trying to find where the reproducing populations are appearing is important. And where those reproducing populations occur, we did some risk assessment of where this might happen. When we started off designing surveillance, and that's what we expect for the future. And of course, we now know we're kind of on the way to seeing that. So our objectives ultimately are framed in two ways. Kind of what's the biology behind this emerging zoonosis? And secondly, what can we do to it? Because if we're producing surveillance to identify risk, that then will trigger some public health response. What can we do? Well, we've no vaccine, and all we can do is provide information to the public about personal protection, environmental control, to reduce cases, and also try to make sure that any cases that occur are treated early by providing information to clinicians and to the public about what Lyme disease is and that it's coming to your neighborhood soon. So the surveillance aims to identify the Canadian population at risk, where risk is occurring, which are the risk populations geographically, but also demographic groups and so on, so that we can target information to those who are most at need, and also get information about the types of Lyme that's occurring, which helps to help practitioners, we hope, but also gives us an idea of how well we're doing about informing people. So Tick surveillance, going out into the environment to try and find the risk, is actually early warning, because when the tick populations are starting off, they usually got ticks at low abundance, and there's a low proportion of the ticks infected. And that takes some years for that to build up. The gold standard method is a combination of this, which is rodent trapping those wild animal hosts, which are out there running around picking up ticks for us and getting infected. So they're a good place to be identifying, collecting the ticks, and then testing the rodents and the ticks for the bug, for Borrelia burgdorferi. In most cases, it's a sensitive way of detecting where the populations are, as I say, because the rodents are always out there in the environment. And it's also a good way of detecting for evidence of infection, because the rodents have been out there being bitten by ticks for weeks to months. The disadvantage is that, well, it's not necessarily very immediate. It's very resource intensive, and so you can't kind of do this kind of surveillance throughout the whole of Canada. One site visit takes 2 days, so it's kind of tough work. A slightly lighter version of that is drag sampling, which is that you take a blanket, like the lady at the top, and you drag it in the herbage, and if the ticks are out there, they will jump onto it, and you'll be able to turn the blanket over and have a look and see that there are ticks crawling around, which you can then take off. You can identify and confirm what species they are, and then test them for the Borrelia burgdorferi. So you get a fairly immediate result, and then a bit later you'll get an idea of what's the sort of risk in terms of what proportion of ticks are infected. One of the disadvantages is that it doesn't really work for Ixodes pacificus, because they tend to quest very, very low in the environment. Out of that, we have been able to bring together through collating studies. We don't necessarily do it ourselves as the Public Health Agency. Usually it's partnership with provinces, territories provinces who are doing it often themselves, and now we've collated the data into kind of into a national picture. And we've produced these data to kind of inform what's happening at the moment. We also have a passive tick surveillance system, which is has been going for quite a long time. It involves ticks collected from patients at medical and veterinary clinics, and it's provided a long data set, good geographic coverage, but there's problems with specificity, because they pick up, particularly dogs, pick up those ticks, adventitious ticks, that are dispersed by the migratory birds. So you find a tick on a dog, but it doesn't mean that there's actually a reproducing population there. But we've worked on methods to make this a much more specific method, and this continuing studies on using passive surveillance, they're ongoing at the moment. And lastly, human case surveillance. It's based on kind of diagnostics. Obviously, the main, and it's clinical and serological diagnostics, because that's the main method used. And of course, within the case definition are those with erythema migrans, and you don't need evidence. The person needs to have had some credible encounter with ticks, but to have that red ring, but no serological response needed. For a confirmed case, you need disseminated Lyme disease symptoms and laboratory result and exposure, but for a probable case, you don't need exposure. And we are keeping this limited, and I must make it clear that the limitations to this is because the post-Lyme syndrome and other syndromes are maybe caused by Lyme disease, but they're caused by a lot of other things as well. And what we're talking about with public health surveillance, and this is not a clinical surveillance case, and we actually make that very clear on the website and everything. So What we're trying to do is to be able to determine from one place to the next where Lyme disease is emerging, rather than being able to capture every single possible case of Lyme disease. And that has been our objective. As we know, that by and large, there's, the cases are occurring where we're finding environmental risk, but not always. So human cases are identifying new emerging areas. Of course, we are seeing increasing numbers, and these are apparently for 2015 an underestimate. We are identifying age groups that are affected, particularly children 5 to 14, and then elderly people like me, 55 onwards. And we get an idea of what is the proportion of cases identified as different stages of Lyme disease. And it's suggesting that we've got a long way to go in getting information out to the public. I'll probably end there, but just leave that slide up, which says that there's a lot more going on than just Borrelia burgdorferi emergence. So I'll leave it there.
Thank you, Nick.